Now let's move on to the features of malignancy. So only when you see these features, you can classify it as a malignant tumor. Starting with anaplasia. So anaplasia is going to be the hallmark of malignancy. So hallmark of malignancy is anaplasia. So anaplasia literally means lack of differentiation. So differentiation is the term we use to denote how far the cell is actually resembling its parent tissue. So suppose a hepatocyte, its function and its structure is to form the bile pigment and all those things, right? So hepatocyte function. So how far a tumor cell is going to resemble the normal hepatocyte determines the differentiation. So from a benign to a malignancy, if you see, as the tumor grows towards malignancy, the differentiation is going to be lost. So a well differentiated tumor is much more going to resemble that of a normal host tissue, while a poorly differentiated malignancy is going to not resemble that of a parent organ. Okay. So this anaplasia, lack of differentiation, is going to be an irreversible change because it is a feature of malignancy. So how does this lack of differentiation appear as? So normally the cells will not be having a polarity. The polarity is nothing but if the this is the basement membrane and the cells are going to be arranged on a regular basis around it, right? This is a squamous epithelium I have drawn. So it is going to have a regular arrangement. So this polarity is lost and they are going to be arranged haphazardly like this. No orientation to each other. So loss of polarity is there. Then the cells are going to appear quite pleomorphic. So difference in the size and shape. Then nuclear irregularity. Then they'll have nuclear hyperchromasia. Along with that, the nuclear to cytoplasmic ratio is going to be elevated. So normally the nucleus is going to form only 1/4 of the cell. So 1:4 or 1:6 ratio. But NC ratio will be elevated in malignancies. That is, the nucleus will be much more bigger and occupying nearly the entire cytoplasm also sometimes. Along with that, you can see various mitotic figures, both typical and atypical mitotic figures. And the classical feature for defining it as a malignancy will be a basement membrane breach. Okay, so the basement membrane has to breach and the cells has to invade. Only then you can call it as malignancy. If the basement membrane is not breached and the same features of this lack of differentiation is there, you always call it as a dysplasia. And that dysplasia is actually a partially reversible change. Okay, so dysplasia is nothing but disordered growth basically. So polarity is lost, this hyperchromasia and all these things are going to be there, but the basement membrane is intact in dysplasia and it is a partially reversible condition. As such, it is going to be a pre-neoplastic condition, so pre-cancerous condition. Okay, so don't confuse it with metaplasia. Metaplasia, we saw it under cellular adaptation, right? So metaplasia is nothing but one differentiated cell being replaced by another differentiated tissue, right? So that was an entirely different thing. So cellular adaptation is always reversible. So remember, cellular adaptation is metaplasia, which is reversible. Dysplasia is partially reversible, which means disordered growth, and it's a pre-neoplastic condition. Then comes anaplasia, which is a feature of malignancy, wherein the basement membrane has been breached and it is irreversible. Okay. Then the second feature of malignancy is local invasion. In fact, it can invade into the local surrounding tissue. That is, it is infiltrating the surrounding tissue, right? So it is the second most common reliable feature of malignancy. Okay, second most reliable feature of malignancy is a local invasion. Then thirdly, we have metastasis. Metastasis simply means there is going to be spread of the tumor to a distant site which is not in continuation with the primary site. So all cancers, all malignancies can metastasize. Exception, again exceptions. So first exception is BCC, which is basal cell carcinoma of the skin. And then we have glioblastomas. Okay, so both of these are going to have early invasion. They tend to invade early into the local surroundings, but they don't metastasize. Okay, and this BCC, in fact, it is called as rodent ulcer. It is going to erode the skin and go and form a burrow kind of thing. Okay, it's called as a rodent ulcer, but it doesn't metastasize, but it causes early invasion. And in pheochromocytoma, if you see, it's a tumor of the adrenal medulla. So pheochromocytoma, in fact, you can call it as a malignant tumor only when metastasis is present. Okay, pheochromocytoma can be malignant only if metastasis is present. Okay. So how do these, what are the pathways by which the tumor cells metastasize? So we have first thing, which is direct seeding of the body cavities. So body cavities like peritoneal cavity, pleural cavity, pericardial cavity, they can be involved by the tumor cells. So direct seeding, the tumors of the organs around the body cavities will tend to spread into those body cavities. Okay. So pleural and pericardial cavity, these can be involved by lung tumors commonly. Okay. In peritoneal cavity, suppose this peritoneal cavity is the most common mechanism by which seeding of the body cavities has happened. So peritoneal cavity is the most commonly involved body cavity. So in this, we are going to have GI cancers, ovarian cancers, appendiceal cancers as well. So these tumors are usually, sometimes they are mucin producing adenocarcinomas. So mucin secreting adenocarcinomas, they tend to involve the peritoneal cavity. The mucin will going to spread over the peritoneal cavity, and that is what we call it as pseudomyxoma peritonei. Okay, pseudomyxoma peritonei is nothing but mucin secreting adenocarcinomas which seed into the peritoneal cavity like a coating. It is going to form, called as pseudomyxoma peritonei. Usual origin is going to be from the appendix or the ovarian mucinous adenocarcinoma. Okay. So the next type of metastasis spread will be lymphatic spread. So it was the tumor cells are going to invade the lymphatic channels, and then they are going to be drained into the lymph nodes. Okay. So usually the sentinel lymph node, which is the first lymph node into the drainage area, that will be involved, and from there it is again going into the other lymph nodes as well. So most commonly lymphatic spread is going to be caused by carcinomas. Okay, so epithelial malignancies, carcinomas, they are going to take up this lymphatic spread for causing metastasis. Exception. So again, exception here. So exceptions are hepatocellular carcinoma, renal cell carcinoma, choriocarcinoma, and then we have follicular carcinoma of the thyroid. So all of these cancers, even though they are carcinomas, they tend to involve the hematogenous spread. So they involve the blood vessels, and then they spread, go for distant metastasis. So I mentioned about the sentinel lymph node, right? So sentinel lymph node is the first lymph node, which is the in the drainage area of the lymphatics. So the sentinel lymph nodes concept is usually important for breast cancers, colonic cancers, even melanomas as well. So in breast cancer, if you see, the axillary lymph nodes are going to be the sentinel lymph nodes. So the exception to this is, there are some times when there is something called as skip metastasis. So in skip metastasis, the sentinel lymph node will be skipped. So sentinel lymph node will not be involved. Instead, other lymph nodes, the next lymph nodes, are going to be involved by the tumor. Okay. So it happens because sometimes for cancer, you are going to give neoadjuvant chemotherapy or radiotherapy before, right? So when you are giving this kind of neoadjuvant chemo or radiotherapy to this tumor patients, cancer patients, so that will cause the fibrosis of the lymphatics. The lymphatics are going to be fibrosed, and there is going to be alteration of the lymphatic channels. So in that case, the sentinel lymph nodes can be skipped, and the rest of the lymph nodes can be involved by the tumor. Okay. The next method of spread of metastasis is hematogenous spread. So as the name suggests, it is going to involve the blood vessels. Usually it is the veins which are usually involved more than the arteries. Why? Because the veins are going to have a very thin wall. So arteries will have a very thick muscular wall, right? So veins have thin wall. So because of that, the metastasis can usually happen easily through the veins. So hematogenous spread, usually it is the sarcomas which tend to involve the hematogenous spread. So exceptions are again there here. So we have a mnemonic called as SCARE. So SCARE stands for synovial sarcoma. Then we have clear cell sarcoma. Then angiosarcoma, rhabdomyosarcoma, epithelioid sarcoma. So all of these sarcomas are going to involve the lymphatics and cause lymphatic spread rather than hematogenous spread. So there are certain tumors which are prone for going into the bone. Okay, so metastasis will go into the bone via this hematogenous spread. So we have a mnemonic again to remember this. So you can use a mnemonic. Please bring limited lunch kit. Okay. So this is the mnemonic we use. So please is for prostate cancer. So prostate cancer usually involves the bone and it is going to be an osteoblastic metastasis. So it is a bone forming metastasis. It's very important. So it's a bone forming metastasis. While breast, lung and liver cancers, these are going to be both osteoblastic and osteolytic. Okay. While intestine, kidney and thyroid cancers, they are going to be osteolytic metastasis. So, osteolytic metastasis is kidney, intestine and thyroid. Prostate is going to cause osteoblastic metastasis, while breast, lung and liver is going to cause both osteoblastic and osteolytic metastasis to the bone. So, this I have already mentioned. Pheochromocytoma, you call it malignant only when metastasis is going to be present. And there is something called as drop metastasis. So, drop metastasis is seen in medulloblastomas because this medulloblastoma tend to involve the CSF, and via the CSF they are going to drop into the spinal cord and they are going to have a discontinuous tumor in the spinal cord as well. Okay. And there is some other thing called as transcoelomic spread. So, it is just using the peritoneal cavity for the spread as such, not involving the peritoneum as such. It is just using to traverse through the peritoneum. So, this transcoelomic spread is going to involve the ovaries, usually bilateral ovaries, and that is given a special name called as Krukenberg's tumor. So, Krukenberg's tumor is transcoelomic spread from certain other malignancies. So, those malignancies are usually from the stomach, breast, colon or pancreas. So, from these stomach, breast, colon and pancreas, there is going to be metastasis and they are going to use this transcoelomic spread and reach bilateral ovaries, producing a bilateral ovarian tumor called as Krukenberg's tumor. Okay.